and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS learning that you can fit into your busy life. My name is Dawn Liz Powell. I'm medical editor at MIMS Learning. Today, I'll be talking to Dr Louise Warburton about the link between obesity and musculoskeletal disorders as part of MIMS Learning ongoing Confidence in Obesity Care campaign. Louise is a GP with a special interest in rheumatology and musculoskeletal disorders. She is also co-president of the Primary Care Rheumatology and Musculoskeletal Medicine Society. Welcome to the podcast, Louise.
Thank you, Dawn.
We know that obesity increases the risk of multiple conditions such as type 2 diabetes and cardiovascular disease, but how can it affect the musculoskeletal system?
Well, it has a variety of effects. And if you start with children, so when children are growing up, if they're carrying excess weight, they need to develop more muscle strength, really, to be able to mobilize successfully. And because our society has changed somewhat since I was at school, when we did lots of hockey, tennis, running around, modern children don't get as much exercise. They don't have as much core stability. So core stability is strength around the abdomen and around the joints, which helps us to maintain an upright posture and a good posture. So it's been shown that when children are growing and developing, their spines are obviously quite mobile and are able to move into different positions. And if they're carrying a lot of abdominal visceral fat, then it can alter the shape of the spine so that the vertebrae, in effect, are sliding forward on each other. And this alters the carrying angle of the spine. So that if that goes on for long enough, it actually becomes set in position when the child becomes an adult. And this can, in effect, have its own problems because the nerves that come out to supply the legs and the abdomen are being stretched into strange positions. And this can cause deferred pain into the limbs. So there are lots of effects in the child upwards. In adults, if you're carrying extra weight, from a young adult, really, this is putting extra strain on the weight-bearing joints. So these are mainly the hips, the knees, the ankles, and there is premature wear and tear really in those joints. So the knees, for example, the osteoarthritic process is a wear and repair process. So most of the time the body's able to cope with the stresses from extra weight. But if this is going on for years and the body mass index has really gone up considerably, then the repair process is not able to cope with that amount of stress. So you then get the position where the joint is beginning to fail because the bone underneath the cartilage is beginning to fail and the joint eventually will need replacing. Those are the main effects in the musculoskeletal system.
So say in the scenario sort of talking about you've got a young child being obese, is that damage or that strain, is it reversible?
Mostly it is reversible in a child if parents were aware of the problem and maybe tried to help their child to lose weight.
Okay, and so what about with an adult? I suppose this is regardless of when perhaps you became obese. How long would someone need to have excess weight before it started to have damage?
That's really hard to say because there's a lot of genetics involved in how people's joints cope with carrying extra weight and also bone density. So if you've been an active child and young adult and you've built up your bone mass, so everyone has a bone mass which they could achieve at the age of 18 or 19 if they were really physically active and strong. So if a person has not achieved that peak bone mass and they're already beginning to lose bone mass when they're going into their 20s and they're overweight, then that's a double whammy. There's lots of different factors involved.
And so you're sort of talking about genetics there, but what about ethnicity? Because we know somebody who is South Asian, for example, is more likely to carry weight around the middle, and they're at risk of diabetes at a younger age, and that their risk starts at a lower BMI. Does that differ by ethnicity?
I don't think anyone's ever looked into the actual ethnicity risks to musculoskeletal problems. As you say, the risk of developing type 2 diabetes is at a much lower BMI, isn't it, in South Asian people? Again, it's about body posture. So if you're of South Asian heritage and you're tending to put weight on around the abdomen, then your body shape doesn't predispose you really to developing those strong muscles in your limbs, because carrying this extra weight, and that's putting extra strain on the knees.
Okay. So we sort of talked about genetics and ethnicity, how important it is to build up your muscle strength as a child being active. But what about, you be disabled and you physically couldn't, it would be difficult for you to be active. But then there's the other opposite situation. You can be an athlete, someone who's played professionally, and then they sort of stop, and then that would make them almost quite prone to putting on weight.
Yeah, the first scenario, you might be looking at someone who's born with cerebral palsy and their muscle tone is abnormal. They're not able to run, for example. They're going to struggle, aren't they? But they could build up strength with the help of a physiotherapist. Where I work, certainly there's dedicated physio programs for people with disabilities to help them attain their full body strength. And the second scenario, the athletic person, a top-class rugby player, for example, yes, unfortunately, when they stop exercising, they are prone to putting weight on, but losing their muscular mass, and it becomes converted to fatty tissue. It's really hard for them, I think, because of their very high impact sporting activities. They're also very prone to joint damage. So I imagine as a professional sports person, it's really hard when you're retired to keep that level of fitness up and prevent yourself gaining weight.
I suppose when you're looking at a patient, it's always about individual care and thinking about that patient, if they are obese, and what were the factors that led them to be obese type thing.
It's just such a lifestyle issue, isn't it, in this country, I think. One mustn't be judgmental about people's weight, because the opportunity to eat unhealthy food is huge, isn't it? There are so many fast food outlets out there. If you want to buy healthy food, that's more expensive than the unhealthy food. So, you just need to understand the difficulties that young adults have at the moment in maintaining their weight, a healthy weight.
But okay, so say, sort of going back to the musculoskeletal sort of side, say somebody comes to their GP and they're talking about knee pain, or they're talking about, oh, my back really hurts, and you might not know their BMI. You can quite clearly see that that person is obese. Like, you try and sensibly say, well, one of the reasons you might be having pain is because you're big. And how do you raise that sensitively with a person?
I always start with an explanation of what's causing the knee pain, for example, or the back pain, and say that maybe the knee joint is not in the right alignment. If it's like a knock knee position, I would explain that and say that this is being made worse by the extra weight that you're carrying around your abdomen. And I think just discussing those facts or presenting those facts in an educational way, most people begin to understand the link. And obviously, if they're going to get defensive and say they've tried to lose weight and can't, then sometimes that consultation is not going to work, is it? And you may need to get them back for a further chat, give them some educational materials or information about a local referral pathway for people to get fitter, basically. So if you just go in and say, well, look at the size of you, what do you expect? I hope nobody ever does that, because that's not just going to work, is it, at all?
Because it's one of the things in our campaign is that you're trying to raise awareness of you need to be sensitive and treat people with respect. I mean, just thinking about that scenario, you're sort of saying that someone is defensive for whatever reason. Maybe you've handled it as sensitively as you possibly can, and the person still doesn't want to talk about it. Is it frustrating then? Someone's keep coming back to you going, oh, my knee hurts, my back hurts, keep going back to you with the same problem. How do you then raise that issue?
Yeah, sure. Well, I've got a few personal examples. I had a patient had knee pain, and I explained everything to him and said if he lost, I think it's 5% of his body weight, that's been proven. It's in the NICE guidelines to improve pain levels. And he went away and came back 6 months later, and he'd lost loads of weight. He was like, oh, my knee pain's completely gone. I had a hospital appointment myself with a rheumatology clinic, and one of the rheumatology nurses there had lost, she's happy for me to talk about her, but she's lost 3 stone then using semaglutide. But she had terrible knee pain, and I used to say to her every visit, "Why don't you see someone about your knees?" And this time she said, "Oh, my knees are so much better. I can actually walk, more than 2 miles." So I would also use examples like that.
Okay, because I think you sort of mentioned 5% weight loss. Is one of the messages to get across that you don't necessarily need them to reach a healthy BMI? Any weight loss could benefit them.
Yes, I think that's important because lots of people become much more motivated, don't they, once they've lost some weight, even if it's only 2 or 3 kilos. It's going to motivate them because they feel better to try and lose some more. I never give people a target and say, your BMI is 35 at the moment, it should be 25. That means you've got to lose 4 stone, because that's really off-putting, isn't it?
Could it be a barrier to exercise as well? Because how do you get around that barrier? Because if you're in pain and it hurts, the last thing you want to be doing is exercise.
Yeah, so you've got to find some low-impact exercise. For example, swimming, cycling, static bike, or actually getting out on a bike. Walking, if you can walk. So I was recently on the EULAR guidelines for safe exercise in inflammatory conditions like rheumatoid. And we discussed the exacerbation of pain with exercise. And the physios in the room told us that this happened a lot. People get more pain after they start exercising again. But if that pain's lasting about half an hour and then going away, they said that's okay and acceptable. If it's lasting more than that and they're struggling the next day, then they need to discuss that with someone and modify what they're doing.
Okay, so it's low impact and it's kind of like a process as well. So it's they've got to have support to exercise in the right way, as it were. Because the last thing you need them to do is do further damage. You sort of mentioned semaglutide before, and at the moment, tirzepatide is the one being rolled out on the NHS. One of the concerns with these drugs, like GLP-1 medications, is the muscle loss that can happen with them. So even if they're taking it on the NHS or taking it privately, what's your concern about that, and how do we address this potential issue of muscle loss with GLP-1s?
So if people don't join an exercise program or are able to do strengthening exercise themselves, then there is a risk that they will lose their lean muscle. And also, when there's a boom and bust cycle, really, when people come off these drugs and regain weight, unfortunately, they don't regain the muscle unless they actively exercise, try strengthening and building muscle. So that's really hard to do yourself. And lots of the NHS programs actually include an exercise trainer so that you're made to or advised to join a program where you're exercising as well. The worry is some of the private prescriptions where people, they just buy it off the internet and it's probably not explained properly. They don't do that exercise and they really lose loads of condition.
Because we know this does happen, that somebody might take a GLP-1 privately, and whether, let's just assume for a second it's a reputable place and that private prescriber has done all the necessary checks, but for whatever reason that patient might not have told their GP. So if you saw a patient who was previously quite obese and then you sort of see them again and think, oh, you've lost a lot of weight and you've lost it quickly, and you suspect they've now got muscle loss because of a GLP-1, how do you approach that issue?
Well, I would explain that to them, really. Well, first of all, you need to actually find out if they have been using a drug like that. And it is hard to ask, isn't it? You need to ask them, don't you? Obviously, they may not tell you. It's difficult then because you may need to start investigating them for abnormal weight loss, doing all kinds of investigations to rule out cancer. So I would hope at some point in that conversation, the patient would admit that they've been using a weight loss drug.
It's kind of going back to that with sort of that basis of individualized care and building that rapport with that patient, so that patient feels that they can trust you, that they can say that they're doing this and that.
Yes, absolutely. That's what general practice is for, isn't it?
Okay, just on the subject of GLP-1s, we know that semaglutide at least has got proven cardiovascular benefits. And then like every day studies coming out like, oh, they're good for this, they're good for that. But do they have any benefits for the musculoskeletal system?
Yeah, we realised a few years ago that adipose tissue promotes inflammation. it actually releases some hormones which promote inflammation in the body. And using the GLP-1 receptor agonists, losing weight reduces inflammation. Some time ago, when the anti-TNF drugs the biologic drugs to rheumatoid were released, it was noted that they also reduced cardiovascular risk and stroke risk in patients with rheumatoid. And then it was discovered that was because of this anti-inflammatory effect. It's helping the joints, but also helping the arteries and stabilising the plaques. The GLP-1s do the same, really, because they reduce the amount of adipose tissue, therefore they reduce the amount of inflammation in the body. And although that's doing quite low-grade inflammation, it has had that effect in obese people to promote inflammation and promote cardiovascular and cerebrovascular disease. If you lose weight, your inflammation levels go down. As regards joints, if you have an inflammatory arthritis and you lose weight, the same thing happens. If you have osteoarthritis, so that's not the inflammatory disease, it's a degenerative condition, there's still some inflammation in those tissues. And the GLP-1 receptor agonists reduce that as well to some extent. So they're working in a dual way, really, on the musculoskeletal system, in that they're improving, reducing weight, but they're also reducing inflammation. So they're, in some ways, they're an amazing drug.
Just to clarify what you were sort of saying before, they have these benefits, but with the caveat that you sort of need the exercise training as well, because what you don't want is muscle loss.
Yes, absolutely, especially if you have an inflammatory arthritis. So you've probably lost muscle anyway due to that.
Moving on to sort of just general pain medication. Say somebody's got a pain medication because they've got a musculoskeletal problem. How does the obesity affect that? Does that affect how effective that medication is going to be?
Some drugs, for example, the opioids, are very readily absorbed by adipose tissue, and the levels build up there, and you may need to reduce the dose that you're giving to the patient because of possible toxicity. So that affects it. And because there's a bigger body volume, so to speak, the half-life of some of these drugs is extended. So not so much the pain medications, but the contraceptive pill, for example, as well. You have to make adjustments with BMI because the level of the contraceptive pill is actually lower because a lot of it's absorbed into the fat tissue. We need to be careful, really. Things like the gabapentinoids, pregabalin, gabapentin, they're commonly used to people with chronic pain. And again, the half-life can be affected. Your patients who is with chronic pain are going to be on a combination of some sorts of opioids and gabapentinoids. It's a sensitive area. Some patients, if they're on high-dose opioids, will develop a toxicity reaction. This is an idiosyncratic reaction, which I think is linked to the amount that's being re-released from adipose tissue. It can have a paradoxical effect and patients get worse pain. So if you're not sure about what goes to good people, I think ask your practice pharmacist to help you out because there's a lot of information that you need to know about dosages.
So I suppose in a situation, we were talking before about somebody's not wanting to confront the fact that, their weight might be playing an issue in their pain. Say that person has got something physically wrong with their knee, perhaps they need an operation. Say if they are severely, or they've got obesity class 3, could they, technically need surgery, but the sort of surgery team aren't perhaps going to accept them? How do you sort of manage that issue?
If you're in a situation like that, again, it's a very difficult situation to manage. But if you use the methods I've just discussed, try and explain to the patient the effect their weight is having on the pain in their knee, what could be done if they were allowed to be referred for joint replacement. If they've got multimorbidity as well, then they fall into that category where they can have these drugs. So you need to explore all that. So there are still referral programs for bariatric surgery and weight loss, so make use of those if you can. But again, just a good explanation. Sometimes they would get benefit from a steroid injection into the knee or the hip. We can do that using ultrasound control to have a look what the joint actually looks like. But again, you can't do that too often.
This is more for my understanding, but like, say, if you're prospective surgery and it's not so much whether the surgeon's going to say no, but it's actually really risky because of your weight.
Oh yeah, I think the orthopedic surgeons would feel shy about saying that, because the anaesthetic risk is higher, because the ventilating someone who's heavy is more difficult, and therefore they may have areas of their lungs which are underventilated and they become hypoxic. There's a higher risk of infection as well post-operatively, because the tissues don't heal as well. Just technically, it's very difficult sometimes just to get into a joint and perform the surgery if someone got very large legs. Risk of DVT is obviously higher as well.
What are your take-home messages to GPs about obesity and the musculoskeletal system?
Be tactful, explain what the extra weight is doing to the musculoskeletal system, the actual physical effects and the inflammatory effects. Build a rapport with your patients, get help from a weight management program or a health trainer or a physio, and hopefully be able to see that patient again and again and develop that relationship, support them, help them lose weight, because that's really rewarding for you as a GP as well as the patient, if you can help them to get fitter, they'll be happier, they'll be able to exercise more and enjoy life more.
Thank you for speaking with me today, and thanks to our listeners for joining us. I've been Dawn Liz Powell, speaking to Dr Louise Warburton about obesity and musculoskeletal disorders. This episode was produced by Jude Owen. Don't forget, you can claim a CPD certificate for listening to this episode. Simply head over to our website, mimslearning.co.uk, and join us next week for more clinical insights.